So my name is Siobhan Steins. I'm a physiotherapist and an academic at Keele University. And if I could welcome our first presenter, Duncan Loader. Thank you, Duncan.
Okay, hello and welcome. I'm very excited to share with you today a QIP project that I've been working on. So, there are no conflicts of interest to declare. So, this is the QIP project that saved Birmingham Children's Hospital $500,000 annually. And hopefully I'll be able to teach you how you can do it too. So, the story begins when surgeries moved from the Royal Orthopaedic Hospital to Birmingham Children's Hospital in 2019. However, we noticed that monetary rebates fell drastically initially. So we looked into why this could be. So was it the number of procedures? Well, the number of procedures were similar and it wouldn't account for such a big difference. Was it the types of procedures? Well, the spinal surgeries performed were the same at both hospitals, so it wasn't that either. And were we just having incorrect results? Well, we checked our results over and we checked the figures and they were all correct. So we found that the root cause of all of the monetary loss was in clinical coding. So we found that incorrect OPCS codes was leading to a mean loss of £4,243 per patient. So just a bit about the clinical coding here. So within the extraction phase, I've highlighted the OPCS coding, but essentially the operation that's performed is written out by the surgeon, and then this is recorded as a code, and this code is decided by clinical coders, who are non-clinical staff, and this code then goes on to generate the rebate for the procedure. So how did we fix the issue? First, we sat down with the surgeons and we decided so we went through the procedures and gave them optimal codes so we could calculate the difference. We met with the clinical coding leads of ROH and BCH to recommend the optimal codes. We wrote out layperson descriptions for the spinal procedures. The coding lead undertook a local education initiative to inform the coders of the importance of their coding and how it affects the trust. We created a spinal coding kind of handbook for the coders, and I think this had the biggest effect overall. And then the project was reevaluated at the midpoint and minor changes were implemented. So just to give a quick example, this is a kind of rough idea of what the spinal handbook was like. Essentially, it just explained spinal procedures in simple terms so that the coders could understand whether it was a big surgery or a minor surgery. So here are our results. Just to summarize, initially we had an 82.16% coding accuracy with a mean difference, so we were losing £4,243 per patient, and after the 5-year QIP, the coding accuracy was 98.4% with a mean difference of only £264. So this led to an increase of £596,000 annually. So, can you do it as well? Yes, we had very simple methodology. It only required a few hours of the surgeon's time to review some of the procedures. The coding team really enjoyed being involved with the clinical staff and just kind of understanding their job a bit better. And the data collection was easy, and even a medical student like myself could do it. So moving forwards, we want to help you do this at your institution. Feel free to reach out to us, and we can put you in contact with the lead coders and help improve the coding at your hospitals too. Thank you very much for listening.
Thank you, Duncan. Any questions from the floor? Well done.
Thank you, Duncan. That's very interesting. How do you see this will help as an NHS organisation as a whole? Because individually contacting your team is only very much localised and very, if somebody's enthusiastic to do it, because having 2 hours of a surgeon's time, that's why there's a shortfall already. That you need somebody who's enthusiastic, but actually it should be driven by the management team, the trust itself, rather than clinicians, because we do a lot of things. Those 2 hours are precious.
Yeah, of course, of course.
So how do you think you can promote this to the NHS England as a whole?
Okay, right. So I agree with you. Your time is very precious. I think that we are happy to distribute the coding handbook. So we can distribute that. Ours is just focused in spinal surgery, however. So I think it's important that a kind of handbook is generated for other surgeries as well. But yeah, I think distributing the handbook can help other trusts, and it won't take any of the surgeon's time. We can just hand it straight over to the coders.
Brilliant. No, £500,000 makes a lot annually.
Yeah.
Thank you.
Thank you.
Thank you. And Duncan, could I ask, is this specific to paediatric surgery, or is this something you're encouraging across the board? Is this miscoding a general issue?
So, well, our surgeries were paediatric surgeries and paediatric spinal surgeries. Talking to some of the general surgeons, we also noticed that it was an issue for them, but it was less the procedure codes that were the problem and more the comorbidity ICD-10 codes that they were struggling with. So I do believe that this would be applicable to other specialties.
Thank you. Yeah, time for one more. Yep.
Yeah, Alex Gibson Stanmore. Thank you very much and well presented. When I was an SHO at Great Ormond Street 100 years ago, we used to write the codes of the operation on the operation note. Now, someone told me you're not allowed to do that anymore, and it's got to be the coders that do it. But I mean, is that something that we could look at? You could do, perhaps.
Yep. So, yeah, I think as we had a question before highlighting the importance of surgeons' time, and so I think the clinical team, the coding team, sorry, should be responsible for writing down these codes. Yeah, I feel like while the surgeons are able to write the codes on the op notes themselves, that kind of extra time for every single surgery, it might add up to a lot more time overall. But I can understand where you're coming from with that one. Yeah.
Thank you so much. I think that coding has also changed in terms of the total modality of the codes that they go to. So it's no more just the OPCS that goes in that we used to put in. I remember doing the same. Let's move on to the next talk. So we have Thomas Slater presenting on comparison of the 5 animal models of disc herniation. Over to you.
Thank you. Good morning, everyone. I'm Tom Slater. I'm a PhD student at Imperial College. Right, so let's get started. I have no conflict of interest to declare. So lower back pain, as we know, is a huge issue, and lumbar disc herniation is often implicated in this. As researchers, we're interested in understanding the mechanisms behind lumbar disc herniation in order to improve clinical outcomes. And so to do this, we use either cadaveric or animal model tissues to herniate in the lab and see what happens. However, when we use cadaveric tissue, it's usually old and severely degenerate, and it's been found that this doesn't herniate readily in the lab. It's uncommon to be able to get hold of young discs, mildly degenerate discs, and whilst these do herniate, due to the difficulty and expense of getting hold of them, it makes doing meaningful studies tricky. So instead, we turn to using animal models for our slides, for our studies. So these have helped us, and we've managed to elucidate that the mid-annulus is sort of the initial failure point in herniation. And this occurs similarly when end-plate junction failure is the mechanism of the herniation. However, these studies led us to a couple of questions. So how did the choice of animal model here, how did that influence the herniation and the result? And ultimately, is this mechanism, is it accurate to herniation in the human disc? Does it translate? And it led us to our study aims. These are to herniate 5 common animal disc models using a standardized load, and to determine whether species and disc types are predisposed to particular modes of herniation. So our study involved choosing 5 common animal models. We then applied a standardized load to all of them. We microstructurally analyzed them for different types of damage present in each specimen. And then we attempted to make a comparison to clinical herniation data available in the literature. So, the types of damage we saw under the microscope. We saw end plate tearing, vertebral fractures, annulus tears, extrusion of the nucleus tissue into vertebra, and finally, the radial nucleus movement. And the way that we chose to display this was using a radar chart, where a 0 on the chart corresponded to none of the segments showing a radial nucleus movement. And like annulus tearing here, when we had a 6, that meant that 100% of the discs showed this. So we found that these models failed in 3 distinct ways. The bovine tail was characterized mainly by annulus damage. The bovine lumbar, porcine cervical, and porcine lumbar discs, they suffered from radial nucleus pulposus extrusion and annulus damage. And the ovine lumbar was characterized by vertebral fractures and a lack of nucleus extrusion occurring. We then made an estimate for how human herniation occurs. This was done using literature data. And we found that it was similar to the bovine lumbar and porcine cervical discs. However, the main outcomes from this was a framework to be able to compare across animal models and ask the question of if an animal model has failed in one way, was it predisposed to that? And how would it look in other animal models? And we've got some recommendations for improving future ex vivo spinal injury studies. That is, that the porcine cervical, porcine lumbar, and bovine lumbar, due to their nucleus extrusion habits, would be recommended for annular-driven protrusion and extrusion type studies. That the ovine lumbar, due to being characterized by vertebral fractures, is probably most suitable for sort of end plate-driven protrusion and extrusion type herniations and failures. And the bovine tail, due to its relatively tall disc height and showing a somewhat lack of damage, might be most suited for implant testing and other studies in that vein. Thank you all for listening.
Thank you for your presentation. I'm Meg from University of Leeds, and I was just wondering, for your loads, did you find specific animal models herniated in one type of loading type compared to the other, and were they kind of converted from physiological values to make sure that each were basically suitable for the different anatomy of the animal models?
Right, so this was a big question for us. How do we choose the load that is standardized across 5 animal models? And ultimately, we wanted it to be somewhat physiological, so to not be bending extreme amounts. But in order to herniate discs in the lab, we do have to apply a hyperphysiological load. If we don't, we generally just don't see anything. There are studies that show if you don't go to sort of 50% of the failure load, you see essentially nothing. So the way we chose those values was by finding from other range of motion data what a sort of maximum physiological kind of level was. There are studies which show in the human how much our spines bend and how much is physiological, and we used all of those to inform our numbers. The loading we also applied was sort of a compression, and there was some shear force as well. These were done using making sure that we were seeing damage in the discs, and our sort of preliminary studies informed what loads to use for that.
Yep, thank you.
That's right.
Thank you. Any further questions? No? Okay. Thank you. Thank you very much. And welcome our next speaker, Mohammed Mustafa.
Hi everyone, my name is Arish Mustafa. I am an academic Foundation Year 2 doctor working at the University of Liverpool and in association with the Royal Liverpool. Today I'm presenting our work which summarizes the outcomes of patients that have been diagnosed with a spinal intradural tumor and gone on to receive treatment. This could either be surgery or radiotherapy. This was work done in association with the Walton Centre. So these tumors are rare. Their incidence rate is less than 1 per 100,000 years of patient follow-up. Majority of these patients that present through the service are symptomatic and they will undergo some form of treatment. The outcomes following their treatment are poorly defined, especially in a larger cohort. And so our primary outcome for this study was progression. This was defined as recurrence following a gross total resection or regrowth following a subtotal resection of tumor. And our secondary outcomes were overall survival and post-operative morbidity or post-treatment morbidity. The way we did this was we did a systematic review and we looked at Medline and MBase databases, and we included all primary spinal intradural tumor studies, including patients over 18 years of age. We carried out a descriptive analysis on our cohort, and these were the variables we included. These can largely be grouped into 4 domains: baseline demographics, tumor factors, operative factors, and radiological factors. I'll give you a second on the slide. We identified a total of about 3,000 articles and ended up including 23 studies in total. So this was a cohort purely of spinal intradural tumors, and we didn't include any dumbbell tumors or tumors with an extradural extension. Most of these studies were retrospective and single center, and these cohorts were largely based in Asia or Europe. In terms of what the cohort looked like, so this represented 1,072 participants, majority of which were female, and their weighted median age at diagnosis was 54 years. All of the weighted medians are proportionate to the number of participants per study. The most common presentations were sensory deficit and motor deficit, and about 30% of patients also presented with pain and bladder and bowel dysfunction. Our weighted median follow-up time was 41 months, so about 3.5 years. The most common first diagnostic modality that was reported was MRI, so this was reported in 20 studies, and the most common tumor locations were thoracic, followed by cervical and lumbar, and the median weighted tumor volume was 3.1 centimeter cube. In terms of what tumors themselves were like, the histopathological subtypes, so half of our cohort consisted of meningioma, with 1/3 consisting of schwannomas, and I've got further subdivisions of ependymoma, hemangioblastomas, and neurofibromas listed. 95% of the cohort underwent surgery as their treatment, with 5% of the cohort undergoing radiotherapy. In terms of our outcome data, so 831 participants had an extent of resection reported after their surgery. Of these, 85% of the patients had a gross total resection, with 15% of patients undergoing a subtotal resection. There were a total of 23 progression events among the surgery cohort, with a total of 3 progression events among the radiotherapy cohort. What's interesting is out of the 26 patients that had a progression, 10 of them required re-intervention. This was either in the form of repeat surgery or radiotherapy for progression. So it's about 38%. There were a total of 40 postoperative complications reported. The most common ones were CSF leak and surgical site infections. Pain was assessed in about 100 patients post-treatment, and 100% of them reported an improvement in pain post-treatment. Neurological function was assessed in about 500 patients, so this was done largely using study-specific questionnaires, and about 85% of patients reported an improvement in neurological function after treatment. So what can we conclude? Surgery remains the mainstay of treatment for these patients, and most of these patients will go on to have favorable outcomes. Among the ones that do have or experience progression, a large proportion of them will require re-intervention. We need further work to investigate prognostic factors for that sub-cohort and also describe their volumetric growth data. Lastly, I'd like to thank the Walton Centre and the University of Liverpool for supporting this work, and our 2 supervisors, Mr. Srikandarajah and Mr. Kaiser. Thank you.
Any questions? I may ask one. Why you think the volumetric assessment would make a difference? Because I think you will operate on, give treatment when there is symptomatic recurrence.
Yeah, so this is actually the volumetric stuff. It's been validated in Liverpool for incidental meningiomas. It's largely a cranial pathology, but the way they've done it, or the pathology that they've done it, is using the volumetric data, you can stratify patients into low risk, medium risk, and high risk, and that informs how frequently you can monitor these patients. So this was a follow-up time of about 3.5 years. But in Liverpool, they're employing a prognostic model incorporating volumetric data for incidental meningioma or meningioma overall, so that we know when to monitor them, whether it's 6 months, yearly, or every 3 to 5 years.
And how you measure the volume? Is it automatic segmentation, or you have to do manually?
So the work that Liverpool's done previously was by one of the previous academic foundation doctors. He did it using the formula ADC by 2, so it's just maximum diameter divided by 2. But there is ongoing work for automatic segmentation, but that's largely based in Manchester. We're not doing that locally.
Thank you.
Thanks.
Oh, don't go yet. One more question.
Sorry, it's a very relevant one. Can I just ask you one question? You clumped everything as an intradural tumor, but the characteristic nature and outcome is different if it is intramedullary or if it is extramedullary. Did you had a chance to look any difference amongst them, or you just seen as an intradural tumor?
So, I mean, for the systematic review, I've just grouped them as intradural tumor and not done a subgroup analysis looking at extradural, extramedullary, or intramedullary. Our groups actually summarized patient-reported outcomes for intradural tumors, and the only, I suppose, relevant point we can find is that patients that have an intramedullary tumor have worse quality of life. But this informs the future study that we're planning at the Walton Centre to looking at long-term quality of life and outcomes for these patients. So I think for that study we can further subdivide them, but I didn't do that for the review.
And the studies you have picked up, those 23 or something, they were also clumped like this as an intradural?
Yeah.
Thank you.
Thanks.
Thank you very much. Well done.
May I please invite the next speaker, Amir Khadmi, presenting on systemic review of vertebral spinal endometriosis.
Hi, so my name is Amir. I'm currently a spine fellow in Israel, and today we're going to discuss a rare topic about endometriosis lesion in the spine vertebra. This is a systematic review that was made under the guidance of Professor Aouja from Cardiff. And our goal was to identify a patient with endometriosis lesion in the spine vertebra and the clinical presentation of that, and understand the challenge of diagnosis in this scenario and assess the treatment to outcome to improve future awareness. So, in brief, what is endometriosis? Endometriosis is an inflammatory condition where endometrial-like tissue cells grow outside the uterus and can causing pain and other symptoms that are beyond our scope of this discussion. But usually the lesions are spared into the pelvic, but there is evidence of a lesion that can spare the site, extrapelvic site, as for example as the lung, and also relevant to us, the nervous system. So what happened that this lesion respond to hormonal cyclics and that causing a cyclic pain. So what does this matter? Because a patient, woman with endometriosis lesion in the spine can mimic common spinal pathology that, for example, back pain, even neurologic deficit, and even was described also hemorrhagic complication. So in this systematic review, the method was the first to do comprehensive research in the database like PubMed and Google Scholar, implying inclusion and exclusion criteria to select peer review articles that and case report that relevant to our topic. After a screening, there was only 15 case reports that were found relevant to this topic. So what is the outcome? First, it's interesting to see that 12 patients did not have a primary diagnosis of endometriosis upon the first referral to the spine surgeon. And the symptoms that was common was back pain and radiculopathy, but other symptoms also have been reported. Lumbar spine was the most affected region. Almost half of the cases reported, more than half of the case report was in the lumbar spine. There is no evidence in the literature of endometriosis lesion in the cervical spine. And regarding the diagnostic challenge, there is 4 of the patient was diagnosed with endometriosis lesion in the spine where they're having already motor weakness. MRI was the major tool to diagnose the endometriosis lesion, but there was several case reports that primarily there was misdiagnosis, and the lesion was interrupted as a tumor or disc herniation. Biopsy was done in 70% of the cases to confirm the diagnosis before the treatment, and surgical intervention was the major common treatment. Either it was the only treatment or combined with hormonal therapy. It's interesting to see that although there's small cases, our study reviewed small number of cases, half of the patients were reported that complete remission of their symptoms after the treatment. So for conclusion, vertebral spinal endometriosis is a rare condition but can cause significant clinical symptoms. It should be considered in the differential diagnosis in patients, especially in young female that having unexplained back pain. It also, multidisciplinary approach is essential to improve the diagnosis and outcome. For further research direction, we need to better understand the link between endometriosis and back pain, especially in cases that there is no involvement of endometriosis lesion in the spine. Research will focus on improving the diagnosis and the long treatment outcome. Thank you very much.
May I ask a question first while somebody's getting ready? You said histology only 73% was positive. That means in 27%, histological confirmation was not there.
Yeah.
And this condition cannot be diagnosed radiologically. You can just see an MR with a tumor, but you cannot say it's endometriosis. So how did you diagnose in the rest 27%?
Only after the case report that what described that they go to do the surgery, and after the surgery, they sent pathology, and that was confirmed the diagnosis. And the other case report would say that they do CT-guided biopsy to confirm the diagnosis before the treatment.
Maybe I misunderstood. I thought you said 73% were positive for histology only of all cases. So I'm just...
I mean before the treatment.
Fair enough.
Hi, just wondering, did you look into management with oral contraceptive?
I took a look. Oral contraceptive was part of the hormonal therapy that I looked. There was either combined with surgical treatment or alone, but yeah.
So does the back pain respond to oral contraceptives?
Part of the patient will respond to that, yeah.
Okay, thank you.
Thank you.
Okay, thank you very much. And we could welcome our next speaker, Michelle Diamond.
Good morning, everyone. My name is Michelle. I'm a medical student at Cardiff University, and today I'd like to talk about my research on the effects of e-cigarettes on bone health. I think everyone in the room would have noticed a rise in the number of people vaping. This begs the question of how much harm do they actually cause, and could there be possible implications on bone health? Before I begin, I'd just like to declare that there were no conflicts of interest. Coming to the background, vaping first entered the UK market in 2007. They are marketed as a safer alternative to cigarette smoking and as a smoking cessation tool, with Public Health England declaring that vaping is 95% less harmful than cigarette smoking, although these were based on short-term studies. Therefore, I wanted to explore with my research what the effects on bone health were with the use of e-cigarettes, as this remains poorly understood in literature. This is a graph taken from the Action on Smoking and Health survey published in 2024. And as you can see, there seems to be a rise in vaping use over the years compared to the use of cigarettes, which has remained relatively static in comparison. And more alarmingly, as shown here, there seems to be a rise in vaping use. So given my concerns of the relatively poorly researched effects of vaping, combined with their increasing popularity, I wanted to look into the evidence we do have on the effects of vaping on bone health. This led me to develop the research question of exploring the effect of vaping on bone health at a molecular, tissue, and musculoskeletal level. A systematic search was conducted in December 2024 with the relevant inclusion and exclusion criteria. For the inclusion criteria, we made sure that a comparison was made between e-cigarette users and non-users, and to also include animal and lab-based studies to broaden the scope of research. Study selection based on PRISMA guidelines was used, and after screening 13,000 studies, 21 studies were finally included in the systematic review. At the molecular and tissue level, these were my results, and data was extracted from 13 studies. As shown in the diagram, at a molecular level, there seemed to be increased inflammatory markers with reduced osteogenic markers, which had a knock-on effect at the tissue level with impaired osteoblast function and stem cell function, which ultimately led to a pro-inflammatory state with reduced mineralization and calcium deposition. At the musculoskeletal level, data was extracted from 8 studies, with 2 studies and animal studies showing no changes in bone stiffness and volume. However, others recorded reduced bone strength and impaired tendon healing. In human studies, there was an increased risk of fragility fractures and increased risk of surgical complications. However, it is important to note that these were both observational studies. Limitations to research included confounding variables, such as vapors being current or ex-smokers, e-cigarettes being poorly standardized in their chemicals and flavorings, and as well as that, there were varying methods and procedures between the studies, and an overall mixed quality of evidence. Therefore, with all this in mind, we certainly can't draw any hard conclusions on the effect of vaping on bone health. But what my study does reveal is that there may be undiscovered risks with e-cigarettes, and that more long-term human trials are needed to understand the risks that our generation is being exposed to. To conclude, I just want to say that the evidence on this topic is very limited, but the results are concerning. And although cigarettes are viewed safer than smoking, they are not risk-free. We should enhance vaping prevention and cessation services to prevent long-term use, and clinicians should consider vaping history in those undergoing orthopedic surgery. However, more research is needed to guide public health policies. Thank you all for listening, and special thanks to Professor Ahuja for overseeing this project.
Thank you. Any questions from the floor? Thanks, Christine.
Thanks, really interesting. I was just interested, is it known how much of the chemicals from the vaping can actually get to the bone? So how much is absorbed within the gastrointestinal tract and then moved to the bone?
So my research explored the effects at various levels. In terms of absorption, the harmful chemicals in the e-cigarettes were more related to the chemicals in terms of so there was glycerol and different vegetable extracts, as well as there being chemicals linked to impaired lung health as well, such as acetylene, which has already been linked to a lot of health implications. So although my research didn't explore that specifically, I think that's something that we should look into.
So do the chemicals get kind of absorbed then from the lung into, I meant lung, not gastrointestinal before, so from the lung into the blood system, is it known that they get actually into the blood and then circulate around the body?
That's something that I didn't particularly look at, but I think I will look into it at a future time.
Yeah, really interesting. Thank you.
Thank you.
Any further questions for Michelle? Okay.
I was just going to ask, was any evidence to say what time period is required to stop and then there is no more side effects? Like did they stop 3 months before any proposed intervention or something, is there an improvement?
Unfortunately, I didn't explore that specifically. From the evidence we do have, so from the report issued by Public Health in 2015, the studies only went up to a year. So at this moment, we don't know the long-term health implications. And with my research, I haven't explored the effects of vaping cessation and how that would potentially reverse the effects that were already there.
Thank you.
Thank you.
Yep, thank you.
Okay, may I request Uday Singh Chima, our next presenter, to come and present learning cum prediction of pedicle screw placement in thoracolumbar spine.
Hello everyone, thank you for attending today. My name is Uday Singh Chima, and this is my project on the learning curve prediction of pedicle screw placement in the thoracolumbar spine. So just a note before I start, these are interim results, and some of them are subject to change. So there were no competing interests or financial relationships that motivated this study. That's always a positive. So the background behind this. So pedicle screws are a critical part of spinal surgery, as we all know. They're used for fixation and stability in procedures such as interbody fusion, as well as deformity correction. And all spinal surgery trainees will learn how to place pedicle screws. Typically, this is done under fluoroscopic guidance. However, in the past kind of recent years, there's been a lot of innovation with this, with navigation and as well as robot-assisted pedicle screw placement. However, there's been limited opportunity for both new spinal surgeon trainees as well as consultant surgeons, and this is due to a wide variety of reasons such as opportunity, costs, implementation, etc. So, our aim was to develop a quantitative learning curve that compares the learning process in both freehand and robotic-assisted pedicle screw placement. So, as to our knowledge, there has been no attempt so far. So we undertook a systematic review and meta-analysis. We started with a total of 428 papers after searching PubMed and Embase. This was then narrowed down to 12 papers in total. The inclusion criteria we set was a single surgeon case series over a period of time. They had to quantify their time per pedicle screw placement, and this was also restricted to the thoracolumbar spine. At this point, 2 papers had to be excluded due to insufficient data, and then that left us with 10 in total. So we then completed a non-linear mixed effects regression on RStudio, and through that we were able to plot a learning curve. The learning curve we plotted was an exponential decay curve, such that the y-axis represented the time per screw, and the x-axis represented the case number. This curve was particularly good as it gave us 3 separate kind of coefficients that we could use to model a learning curve, and these were ASIM, which represented the peak performance a surgeon would operate at after beating their learning curve, the coefficient C, which represents the difference between their first pedicle screw placement and their peak performance time, and lastly K, which represents the learning rate. And the learning rate essentially is just a number, but a higher number represents a quicker rate of learning the given technique. So the results that we got from this were, for freehand technique, we found that the peak performance time was around 4 minutes, and the difference between their starting time and their peak performance time was around 7 minutes and 39 seconds, and the learning rate was 0.07. Given by itself, this doesn't mean much. And for robot-assisted, we found that the peak performance time was 3 minutes and 6 seconds. The difference between the starting time and the peak performance time was 6 minutes and 46 seconds, and the learning rate was 0.07. So when comparing the two, we can see here that the peak performance time of the robotic-assisted pedicle screw placement was about 54 seconds higher than that, or quicker than that of freehand. However, the deficit or the difference between the starting time and the peak performance time was much higher in freehand. However, what I thought was very interesting about this is our best model of both produced the same learning rate. And so what this means is we could produce a kind of an individual adjusted performance curve looking at how quickly it would take a given surgeon to reach maximum proficiency. So we found that after 22 screw placements in both freehand and robotic screw placement, surgeons should become kind of 80% proficient or overcome 80% of the learning curve. And after a total of 61 screws, they'll become fully proficient in the given technique. So that's just a summary of exactly what I've just said. And then discussion. So what are the take-home points here? So I think there's two ways of looking at this, or two separate points. So we've reiterated what the primary studies show in that robotic pedicle screw placement or robotic-assisted pedicle screw placement produces both better starting times and faster peak performance times. Now, the actual integration of this is quite tricky because it's not like we can provide robotic assistance at every single spinal center everywhere in the world. That's obviously quite tricky. However, I think it's important to note that if we have spinal surgeons training earlier in pedicle screw placement, that they can reach essentially proficiency or full proficiency at the same time as a freehand technique. And then lastly is the use of learning curves kind of in general, not just for what we've done here with robotic assisted pedicle screw placement, such that the typical way of judging competence of a surgical trainee nowadays is a senior surgeon looking at a trainee and kind of judging their competence over a period of time, just watching them train. And a long keep has been the surgical logbook, but if we look at it as it is, the surgical logbook is just essentially a number of cases that has no actual meaning, it's just an arbitrary number. So if we use a mathematical learning curve like we have here, we can use the logbook to make a predictive tool and kind of give more guidance as to how far they've come along their training. So yeah, so thank you all for your time. These are just a thank you to everyone that's helped me, especially Austin Coe, who's also here, who's helped me along the way as well. So thank you, everyone.
While Nick is coming for his question, let me ask you, in practice, in real practice, how would you measure the time?
Pardon?
In the real life?
Oh,
how would you measure the time?
Of pedicle screw placement?
Yes,
well,
from one to the other.
Well, this is slightly the issue. So the papers that we looked at had none of them really specified what their time per pedicle screw actually was. Is it the time you make the incision and then start looking at the thing? So this is the issue. Then if we want to do this kind of, continue doing this and continue getting papers, there has to be a standardized way of measuring pedicle screw time. Our learning curve that we produced did have a random effects kind of incorporated into it, which kind of accounts for it. But yeah, so as it stands right now, there is no traditional way of looking at what a single pedicle screw takes or a standardized way.
Thank you. Nick.
Nick Carnbland from Liverpool. Was time the only metric of competence?
No, so at the time of submitting this, which was, I'm not sure how long ago, a few months ago, it was only, what we'd done for analysis was only the time per screw. However, we're also looking at total operative time, because total operative time will include the setup time of the robot as well, because obviously with time per screw, you're kind of ignoring the setup time. Additionally, we're trying to look at post-operative outcomes as well. So for example, leg pain, sickness, things like that, or even redo rates. But the thing is with that, when you're comparing these, that like we're talking about just here, there has to be a standardized way of comparing between papers, which is also quite hard to get.
So I'd argue that time is not competence, time is familiarity, but you can bang in some screws and do a really poor job. I'd also say that robotic, the accuracy is guaranteed by the robot, whereas freehand there's a lot more cognitively going on. So I'm surprised, did you say that the robotic and the freehand was the same curve, 22
Yeah,
screws?
the same learning rate.
Even though with freehand you're having to image interpret and look at the anatomy, versus a robot where you're working down a fixed channel.
Well, I think the important part, like you said, to keep in mind here, is that this was just time per pedicle screw. But like I said, when the full analysis, also operative time, post-operative outcomes. So when we look at that as well, the learning rates for them aren't the same. This is just exclusively looking at a time per pedicle screw placement. And although the rate is different, there's a different in time still. That's still a thing as well. So whilst you're correct, there's also kind of other factors in freehand. It's just specifically looking at the time it takes to put a screw in. So
no, fair enough. I think it's well presented. I don't know if we should be using that as the metric of competence.
Thank you.
Thank you.
Okay, thank you very much.
Cheers. Thank you.
And our final speaker, if we could welcome Kaushik Ghosh. Thank you.
Good morning, everyone. Maybe just afternoon. My name is Kaushik Ghosh. I work in Preston in Lancashire. I just wanted to share our experience, a longer-term experience of intradural spinal tumor, so only the surgical bit. No conflict of interest. So anatomically, spinal tumor could be extradural in location, but intradural is more common for soft tissue spinal tumors. And when it is located within the spinal cord, it's intramedullary, and within the spinal canal, inside dura, but outside the spinal cord, it's intradural extramedullary. It's important, initially we thought we'll look at in general, but the outcome, the presentation, it's different, so I thought we'll see differently. So as you all know, the common intramedullary lesions are ependymoma or astrocytoma, sometimes hemangioblastoma, and I'm glad it's very similar to your systematic review, Mohammed. And intradural extramedullary is meningiomas and schwannomas. So with that in mind, we looked at our records over last 12 years or so. There were about 110 patients, but we excluded some because not adequate data were available. So 85 patients were included, out of which 65 were intradural extramedullary and 20 intramedullary, and the mean follow-up was 5.33 years. So again, I've segregated the both groups separately for presentation, and it looks like it's very similar to your systematic review, the presentation. Interestingly, sphincter disturbance is quarter of a patient in both the group. So it's not more common in intramedullary, which we expect normally. Weakness was, as expected, was much higher for intramedullary patients. So a few examples. 58-year-old nurse who presented with worsening myelopathy. I still remember I was on call Christmas Eve, and she stopped walking and presented to hospital. And you can see a large tumor filling up almost whole of the spinal canal and going outside to the foramina as well. So it came out to be a large neurofibroma. This is interesting, a 35-year-old lady who fell down in the road and started having back pain, and she never had any other symptom apart from that. And the back pain started after the fall, so everybody was just thinking it's a musculoskeletal. 6 months he continued to have back pain and finally got an MR which showed this. And it came out to be a myxopapillary ependymoma from the phylum terminally. And this is a 68-year-old gentleman who presented with worsening myelopathy, predominantly hand symptom to start with. And you can see a large intramedullary lesion. The actual contrast-enhancing area is behind T7, T1, but you can see quite extensive edema and serings related to the tumor. We managed to excise, so I put a 6 months follow-up scan on the right side. So histology-wise, as expected, the majority of intradural extramedullary was meningioma, followed by schwannomas and neurofibromas. But there were quite a few other things. There were 4 myxopapillary ependymoma. So I kept it under the intradural extramedullary side, whereas intramedullary majority, as expected, is ependymoma. In our series, we had only 1 astrocytoma. Now, I looked at the symptoms at 6 months. Compared to preoperative symptoms, all of them you would expect to improve, which has, but it's not as good as the systematic review you have shown that nobody has pain. We still had 25% of patients some amount of pain in their follow-up. Sphincter function, 7% had still ongoing sphincter function. So complications, pretty similar, CSF leak, wound infections are the common one. We got complete paralysis, 1 in each group, and worsening paralysis in another couple of patients. The patient who got paralyzed in intramedullary group never improved, but the patient who got paralysis after intradural extramedullary meningioma, she did recover. So looked at the recurrence and extent of resection. Wherever we managed to do gross total resection, the total recurrence were only 2. one in intradural extramedullary and one intramedullary. The one intradural extramedullary was a phylum terminally myxopapillary ependymoma who ultimately needed radiotherapy, and that has stopped any further growing. In the side of subtotal resection, 3 intradural extramedullary recurred and 6 intramedullary recurred, and some of them needed further intervention. Looking at the follow-up scans and recurrence, so you can see total 7% of intradural extramedullary has recurred, whereas intramedullary 35% has recurred. And this is in line with the literature. Now, I looked at the follow-up scans. There were 6 mean follow-up scans for patients in their follow-up period in intradural extramedullary, whereas 9.8 in intramedullary. An average follow-up period was 5.33 years. Interestingly, amongst the intradural extramedullary scans, only 3% of the total number of scans had recurrence. So you can see average 5 into 65. 300 scans, only 9 of them has shown recurrence. So to summarize, surgical resection is a reasonably safe option, especially for intradural extramedullary, not always possible for gross total in intramedullary. Recurrence rate is really low in case of intradural extramedullary if there is a gross total excision, which is just 1 in our series. It's expectedly high in case of intramedullary, especially because of subtotal resection. So, I mean, I have drawn one query, and I will request the House for comments that, what should be the protocol for surveillance in case of total excision of intradural extramedullary in the background that the recurrence rate is really low, but general practice, speaking to people and some literature, people tend to follow-up scan at least yearly for 5 years. Is that really necessary in this background scenario of NHS? Thank you.
Any questions? Yeah.
Thank you for your presentation and showing your case series. My name's Nish, I'm from Liverpool, a consultant there. In terms of your practice generally in your unit, there were some complications of paralysis, which is not unexpected at all because this is a low volume, high risk surgery. What's your take on using intraoperative neuromonitoring for these cases? Do you use it in certain subtypes or for everything when it's intradural?
I didn't go into all those details here because of time constraint. Yes, for intramedullary tumors, we definitely use intraoperative monitoring. Now, there are a lot of debates. If the patient is already significantly paralyzed, how is that going to help? We had cases where the patient has grade 3 power preoperative, but when you start monitoring, there is no response at all, amplitude completely 0. So how is that going to help you? In my practice, what we have found, people who has reasonably good amplitude, reduction in that gives a good guidance where to stop or where to give a break. And intradural extramedullary, not necessarily we use in all cases, especially if it is in lumbar region, we just use nerve monitor or nerve stimulator. But a large one in thoracic and cervical, we do use monitor.
Okay, thank you.
Thank you very much. Thank you very much. So our time is up. I'd like to extend again a thanks to all our speakers. Well done, and thanks for your participation.
I'd just like to welcome Professor Senapati to the stage. He's a consultant surgeon in bariatric and metabolic surgery at the Salford Royal Hospital, and also honorary professor at the University of Salford.
Good afternoon. At the outset, I would like to thank the Executive Committee for inviting me to speak. so I don't have any disclosures. Currently, we live in an epidemic of obesity. Out of the 8 billion population globally, 2.7 million or billion are obese or overweight, which is a worrying factor. In the past, our gadgets were bulkier and we were slimmer, and currently the other way around. However, one of the worrying factors is the childhood obesity. Almost a quarter of our children are either overweight or obese. So the basic unit we use is the body mass index, as you all know, measured by weight in kilograms by square of height in meters. And the normal BMI is 19 to 25. If one's BMI is more than 25 but below 30, we call it overweight. But once it is more than 30, we call it obesity. So along with the weight, if we measure the waist circumference of an individual, which is a reflection of our central obesity, it gives a better indicator with regards to the associated conditions like diabetes, cardiovascular risks, and even risk of cancer. So what is obesity? It is not just overeating. It is not an addiction, but it's primarily an accumulation of fat in the body sufficient to cause damage to our organs due to abnormal or excess adiposity. So what are the current patterns and trends of obesity in the United Kingdom? 7 out of 10 men and 6 out of women out of 10 are either overweight or obese in the United Kingdom. Similarly, 3 out of 10, both men and women, are obese, means BMI more than 30 in the United Kingdom. But if you look into the trend of obesity over the last 3 decades, the incidence of severe obesity, which is the BMI more than 40, has pretty much trebled for both men and women. So what is the impact of obesity on our health? There is not a single organ in our body which is spared by the effects of obesity. Starting from your head to toe, it can be intracranial hypertension, stroke, sleep apnea, diabetes, cancer, fatty liver, and NAS. So in other way around, it can have a mental health effect, metabolic effects, mechanical effects, malignancy, and miscellaneous. So what are the mental health can arise from obesity? It can cause you anxiety, depression, intracranial hypertension with visual field changes, or risk of stroke. Metabolic effects like type 2 diabetes, hypertension, dyslipidemia, which together called the metabolic syndrome, and there is fatty liver and NAS, or non-alcoholic steatohepatitis. This is currently the most common cause of liver failure, even more than alcohol in the past. So what are the mechanical effects? It can cause osteoarthritis, more degenerative changes, and other mechanical abnormalities, and backache. So there can be a compressive effect because you are carrying, one is individually carrying more weight, so there's more load from the top. There is also change in the center of gravity, so because of the lumbar lordosis, and also more torque pressure to the facet joints in the spine. So it is also a perfect storm for cancer because of the systemic inflammation and other various mechanisms in the cellular level. This is currently the most common cause or most common modifiable cause after smoking. So there is also lifetime risk of cancer 1 to 2. And there is evidence showing that if you lose weight, there is risk of cancer comes down. At a bariatric center in Salford Royal, we have direct connection with the St. Mary's, which is a gynecological cancer center. Patients who develop atypical cells in the uterus, or they got early cancer, when they referred to us, they had undergone weight loss surgery, we compared them, and they go through remission. Their typical cells become normal, or their early cancer disappears. So if you look back to obesity, age or incidence of obesity goes up, your risk of diseases like diabetes, cancer goes up. So it not only affects your morbidity or associated conditions, but also it has an effect on your mortality. So if you look here, somebody, young 20-year-old chap with a BMI 45, they can lose up to 13 years of their life. And evidence suggests that if your BMI is between 30 and 35, you can lose between 3 to 5 years. If your BMI is more than 40, you can lose up to 8 to 10 years. So people have started looking at the cost of obesity in the United Kingdom. It thought maybe sort of around 58 billion, but the last study in 2021, so it could be 100 billion, both direct and indirect costs to our GDP. So what is the impact of obesity on health? It increases the comorbidities, it reduces the quality of life, increased morbidity and mortality, greater healthcare cost, and loss to the economy. So what are the drivers and determinants of obesity? It could be genetics. Biologically, we're driven to save energy in case of emergency. And there is also, we live in an environment of ultra-processed food, which has impact. And there's also drivers of the economy and the social media. So what is the cause of obesity? It is a complex mechanism leading because we live in an obesogenic environment. There are no single gene effect, but there are epigenetic changes in the loci of our genes. And that triggers to save energy, and this in excess accumulation of fat impairs the cell function. So this is a busy slide, impact of obesity. Because of the various adipokines, the interleukins, the transferrin produced, that causes produced from the adipose cells pretty much affects every organ of the body. So it is a very busy slide, so make it simple. So fat cells are visceral fat cells, produce adipokines, involved in a lipidic and glycemic metabolism. So it keeps the body in a state of chronic inflammation. And that causes the insulin resistance, hyperglycemia, hypertension, and also there is ectopic fat distribution. So what are the current treatment options? So currently the new drugs, the semaglutide, tirzepatide, which has come only a decade old, but the search for the drugs to tackle obesity is over a century. Initially start the fenfluramine and phentermine to reduce your appetite, but because of the complications of cardiac valvular disease and pulmonary hypertension, they came off the market. Similarly, sibutramine came for weight loss and weight management, but it interfered with the serotonin pathway, helping you reduce your appetite. But again, the SCOUT trial showed that it has an effect on non-fatal stroke and cardiac effects, hence it was discontinued. The current drugs of semaglutide, which is called the GLP-1 agonist, initially approved by the FDA 2017 to treat diabetes. But when people started noticing that people started losing weight and the cardiovascular risk come down. So the Wegovy, which is approved by FDA in 2021, but along with the weight, you need to have an associated condition to be prescribed, like diabetes, hypertension, or hyperlipidemia. Then it also approved in the use for children as well. Tirzepatide, the new kid in the block, is both GLP-1 and GIP agonist. It helps to reduce your appetite and hunger, and evidence have suggested that it causes reduced appetite, controls better blood sugar, and also delays the gastric emptying. The patient feels full, so they don't get the noise what you call the obesity environment noise for hunger that comes down. Or various trials, the SELECT trial has shown the weight loss could be 5 to 10%, but if you continue, it may be up to 20% of your excess weight, not the total weight, but excess weight. Similarly, there is sort of minor side effects. Some people cannot tolerate it because of the nausea and vomiting. Very rarely, they may get acute pancreatitis or bowel obstruction or gastroparesis, means the stomach doesn't empty, then they have problems. So if you look back to the history of bariatric surgery, in 1950s, surgeon noted, like any of your surgical colleagues, so we all evaluated over a time depending on the demand for the society. Surgeons noted that if you lose your small bowel by trauma or strangulated hernia, where there's a lot of small bowel resection, people lost weight and they didn't regain the weight. Similarly, patients had surgery for the stomach, either for cancer or ulcer surgery in the past. It used to be more common before the PPIs came into market. These patients lost weight and their diabetes got better. That's why surgeons started innovating. So this is in 50s. Varco described what he did. He bypassed a lot of small bowel. So the middle is the small bowel, the bigger one, the large bowel. He did a jejunostomy. Then came Edward Mason. It's called the gastric transection, where you made a small stomach by transecting the bypass the loop of jejunum. Scopinaro, he's an Italian. They like big salads. So he made a bigger stomach pouch. I think this is not working. So they made a 400 ml of gastric pouch and bypassed pretty much most of the small bowel, just leaving around a 75 centimeters of small bowel. So your small bowel could be in 4 meters to 10 meters. So he left only small. But because of the big sort of stomach pouch, it produced acid. Then they developed ulcers in the small bowel. So then Hess described what called the duodenal switch, where they would do the sleeve of the stomach and bypass the small bowel to the duodenum rather than the stomach. So that reduced the ulceration. When we talked about the gastric transection, because of the horizontal transection, the fundus of the stomach start dilating, and then the patients regain weight. So then Torres described what called the vertical gastric stapling, means they use the thicker, smaller, lesser curve of the stomach. That's what we use nowadays. So this is the vertical gastric stapling with the bypass of the small bowel, so you don't get the bile reflux back. People wanted simple procedure. That's the in 90s, the laparoscopic gastric banding came into practice. It was used for a couple of decades, but because of the problems, failure, the slippage, erosion, this can out of favor. Now, pretty much we don't do any bands. We remove the band, do something else. So if you look into the randomized clinical trials, whether your body mass index is below 35 or more than 35, it always favors surgery. So why surgery? Because non-surgical treatments are not effective in the long term, as evidenced by the Swedish obesity study and meta-analysis of the randomized trials. Obesity surgery is the only proven method of sustained weight loss. And it can improve or cure your comorbidities like sleep apnea, diabetes, and various other factors. And the risk of surgery is very small in comparison to staying obese. So this is what we call the proximal bowel hypothesis. So when you do a bypass, you make a small pouch in the stomach, then bypass the small bowel. So by excluding the proximal small bowel, it excludes what we call the anti-incretin, and that sort of helps with the weight loss and diabetic remission. So this is called the foregut hypothesis or proximal bowel hypothesis. In this one, where the food from the small pouch goes straight to the small bowel, and that stimulates the Leydig cells of the small bowel, and that produces the GLP-1, GIP, all the different hormones we talked about. So this is called the hindgut hypothesis. So if you look into the roadmap of metabolic surgery, you can look in that in early 30s to 50s, surgeons saw or noticed that patients with a surgery, they lost weight. So as the incidence of obesity started rising following Second World War, surgeons started doing bariatric surgery or metabolic surgery, then various randomized trials, then mechanistic link in the rat model, showed the evidence, then publication of various randomized trials in the literature, then it became a standard of care by the diabetic care, which produced guidelines for metabolic surgery. So then during that time, the New Scientist published one of the most significant changes in treating diabetes since the discovery of insulin. So how does surgery improve? One, gut hormones. There are probably 20 different gut hormones like GLP, GIP, glucagon, all sorts of things. There is increased absorption bile acids, pool, so that makes you sort of try to improve your diabetes and risk your appetite. There is a lot of change in the gut microflora. Currently, as you know, this gut microbiota is a 100 billion market. There's also nutrient sensing. So all these various mechanisms, what that do? They lead to increased insulin secretion from the pancreas. It causes increased insulin sensitivity in the muscle tissue, in the liver, and that leads to increased satiety and weight loss. One of the things we noted that immediately after surgery, especially bypass, if somebody is diabetic, they become euglycemic, means they don't need any diabetic medication. Of course, it depends. If they're on insulin for long term, for 10, 15 years, may be difficult, but if they're only within 5 years, their diabetes gets better pretty quickly. You come off medications. Also, it is helpful for the cardiovascular risk and mortality risk reduction. So what are the clinical evidence suggest? All the randomized trials and the long controlled studies, the better glycemic control, reduction in medication usage, reduced cardiovascular risk, stroke, cancer, greater weight loss, and better quality of life. So what is the impact of obesity on spine? Because you're carrying more weight, so you see more spine pathologists with obese people. We did talk about the mechanism, how it occurs. It's 5 times more common in obese people than general population. It also, high BMI has demonstrated, looking at the literature, that there is a higher rate of complication, both elective and emergency spine surgery. And also, especially when you're thinking of fusion or using metalworks in the spine. Of course, obesity adds extra complexity to the spine surgery, so you need to be careful, the patient selection, the procedure selection. Some of these patients had significant comorbidities like a poor diabetic control or cardiovascular risk or sleep apnea. You need to optimize before you plan for surgery. And there also, you have to modify the surgical techniques you use. People talk about the microscopic or endoscopic surgery. Obviously, you need the skills and training, all those things, so you need to plan the surgery. And the outcomes, you need to be aware of the limited outcomes, or you need to understand, explain, and consent to the patient. Also, it's also difficult, these patients, to do physiotherapy because their mobility is limited, and there may be technical difficulty in giving injections. And you need to be aware of these patients' limitations on mobility and transfer. Even imaging, they may not fit into your standard CT scan, so you need to think of how to image these patients with backache. Of course, intubation is a challenge for obese patients unless your anesthesiologist is trained to intubate obese patients. Somebody with 50, 60 BMI may be challenging. It may be difficult in positioning. You may use 2 tables rather than 1 table to fit in them. There may be limited usage of imaging. If they don't fit in, you may not use your standard imaging tools. And of course, there is always increased time, bleeding, and infection rate. So post-operatively also, it showed that there are inferior outcome with patients with obesity. So you need to be very careful and precise in selection of your patients. And obviously, you need the appropriate infrastructure. So what are the current surgical options to tackle obesity? So if you divide types of surgery, you can talk about restrictive operations, malabsorptive operations, or combined operations, or miscellaneous. Out of all these 2, currently in the United Kingdom, we do sleeve gastrectomy as a restrictive operation, and the combined operation gastric bypass. because malabsorptive operations need a long-term follow-up, they need the support, so we don't do those operations. So this is a sleeve gastrectomy. We're taking part of the three-quarter stomach out. So normally the patients are positioned like this. We like to stand between the legs. And pretty much all the operations do is keyhole or laparoscopic, minimal invasive technique, putting different ports. This is the video clip. I'm using harmonic scalpel. That's the greater curvature of the stomach. We're devascularizing the greater curvature of the stomach. We divide all the short gastric vessels along the greater curvature of the stomach. That's the spleen there. We need to bring down the cardioesophageal angle to bring the fundus, because fundus is where the ghrelin is produced, so we need to make sure that we free the whole of the stomach so that we can excise the part of the stomach. Once I've freed all these, we ask the anesthetist to put an orogastric tube, which is sort of 40 French. Just lateral to it, you use the staple guns, which has 3 rows of staples on either side and blades cuts in between. We need to make sure that the tube or the narrow tube is not twisted or not in a good anatomy, so that they don't develop postoperative dysphagia problems. And once we have excised the around three-quarter of stomach out, we need to make sure we control the bleeding, putting clips or using a tissue spray. Then we check with the methylene blue, make sure that there's no leak from the step line. And this is what when it comes out. And most patients stay a day or two in the hospital. We've done some work 10 years ago about the ambulatory bariatric surgery, where they can go home within 23 hours. So this is gastric bypass. This is a schematic diagram with a small video clip as well. So again, that's the liver. I lifted the liver up. We make a small pouch in the stomach based on the lesser curve of the stomach, the thicker side. I make an opening in the small pouch. Then that's the small bowel. I'm picking from the DJ flexor downwards between 50 to 100 centimeter. I don't look in the length. I like to see that there is no tension with your anastomosis to reduce any complications. Then we do the anastomosis, small bowel to the pouch, and we use both sort of staple technique and hand suturing, keep your competency good. Then we do the jejunostomy to do the Roux-en-Y bypass. Again, similar sort of technique. So I'm measuring the small bowel between 100 to 150 centimeter of the small bowel bypassing. Then we use the staple technique to do the anastomosis. Then close again the opening. Once we've done this, because we use different techniques, because if you divide the small bowel before, it'll fall down, so you're not able to do it. Then I'm checking the anastomosis and the staple line with the blue dye, make sure there's no leak. If at all, you can fix it at the time rather than having problem. Because you move the bowel in and out, there is a risk of internal hernia. So this is what I close in the mesenteric defect with a non-absorbed suture. Similarly, there is another defect called the Peterson defect. We also close the Peterson defect to reduce an internal hernia, which can occur within around 1% in the long term after bypass. So what are the complications? Like any anesthetic complications, the risk of bleeding, infection, leak, risk of DVTP, all these patients put on the fragment for DVT prophylaxis, depending on the BMI, can be 2 weeks, between week to 4 weeks. And there's also small risk to life. Normally, we don't do any banding, but if you do a sleeve, we expect to lose around 60% excess weight, but with bypass, around 70% excess weight. We don't do the BPD DS normally. About the type 2 diabetes remission, if your C-peptide is good, means your pancreas is still functioning, then your chance of diabetic remission, either partial or complete remission, is better, and you're not on insulin. So what are the current outcomes of diabetes and metabolic surgery? It is safe, low morbidity and mortality, and the risk of surgery is like having a gallbladder or a knee operation or a hysterectomy. It is so safe. More effective in comparison with other treatment options, improves, reverses many of the diabetic-induced, obesity-induced dysfunction, increased mobility, better quality of life, and social well-being, and it is acceptable. The financial outlay justified within 3 years of surgery, and more so in a diabetic patients. And also by these patients are back to work and activity, so it is less impact on the employment, they can get back to employment. Like any registry in any specialty, we've got the National Pediatric Surgery Registry, where all the records are documented. And the third report, which looked into 70,000 patients, looked into 40,000 patients. You can see the in-hospital mortality is 0.04, so 4 out of 10,000. So it's very rare. And a lot of patients improved with their diabetes, and you can see the outcomes after bypass is around 70% excess weight loss. So in the past, these patients struggle spending more time in the lounge. Now they go out, they look into all the parks, their quality of life has changed. So Simon, who was spending more time in the pub, now he's a globetrotter. Some of the parents, while the children are doing activity, spend sitting there or having a chocolate and a biscuit or a tea. Now they can play with their children. John, who was struggling, I think he's a physiotherapist, and he was huffing and puffing before surgery. After surgery, now he did half a marathon. Yeah, Lisa, who had a type 2 diabetes, and she was secondary infertility. After surgery, she comes to the clinic with the baby now. So we need to start thinking, we need to stop this obesity epidemic. We can't just ignore what it is. We need to check our weight regularly. We need to keep an eye on your waist circumference. We need to choose healthy choices because we're surrounded by high, dense, rich food. So with this intent and to increase the awareness, I founded this society called the OSGB, Obesity Awareness, which is a decade old now. Now we encourage patients who lost weight. As a social community advisor, we encourage them. So what are the current weight management issue options for the spine surgeon for your practice? If you want patients to lose between 5 to 20% excess weight, then you can try the semaglutide or tirzepatide. If you think that weight loss is helpful with planning your surgery. Normally, sleeve gastrectomy is indicated if you don't have reflux, if you're not diabetic, your BMI is 40-45 or quite high because you can't do the bypass, then sleeve gastrectomy option. But if you have reflux or diabetes, then think of the bypass. And of course, like any outcome measures, this is a holistic approach. You need to see the dietitian and the specialist nurse so they can help you to get the maximum weight loss and benefit. Of course, like any specialty, we talk about the AI because obesity is defined more than 30, but clearly recently there is a big article published by the IPSO in the Lancet. We can't just say weight is the only issue. We need to see the organ dysfunction. Then only call the clinical obesity or preclinical obesity. That's where the risk of, so the AI can help us, machine learning about the impact of obesity on health. And also, rather than surgery or medicine, no fighting, we look into the combined approach. Well, what gives us the best? Whether it's medication first or surgery, then surgery and medication together, so all those things will help us in future. Of course, that also helps you in the risk stratification and a better outcome. We know the NHS is already struggling and obesity doesn't help. We know it is a preventable condition, but it kills. So we need to follow the simple principles or ABC of healthy living, which is adopt a healthy habits, balance your calorie intake, and control your weight.
Professor, I'll just have to ask you to summarize. Oh, thank you. So I'd like to say a big thank you to Professor Senapati for his wonderful talk. Do we have any questions?
My name is Donald O'Donoghue. I'm a retired spinal surgeon and currently medical director for ABL Health, which we've had conversations in the past. I wonder if you could say a little bit about the kind of pre- and post-operative care, pre-bariatric surgery and post-bariatric care. The reason I'm asking is very rapid weight loss has very negative impacts on the musculoskeletal system, as you know. We've encountered, to a degree, anecdotal cases where back pain has significantly increased after surgery rather than reducing. We found very little in the literature about any systematic evaluation of back pain after obesity surgery. So I'd be interested in your thoughts.
Oh, thank you for your question. Yes, many of these patients in the National Health Service, as you know, they go to Tier 3 service and they spend between 6 months to 2 years before they're being referred to the Tier 4 center in Salford, wherever the Tier 4 center in the NHS is. And then they see the team, they see the surgeon, the physician, the dietitian, the specialist nurse. Then they discuss in the multidisciplinary meeting, then put in the waiting list. And then they may spend another year or two. Of course, the surgeries who choose nowadays, both sleeve and bypass, the weight loss is progressive. It's a slowly but losing weight because they need to be liquids for 2 to 3 weeks, semi-solid weight, then the solids, and the weight loss is gradual. We don't do the complex BPDs or those surgeries. Obviously, if the patient is not eating and drinking, then you need to get them back in, make sure that there's no cause for rapid weight loss. Yes, it's very important. That's what they need, the support from our dietitian or even physiotherapist if required to do the activity. Because whenever you lose weight, you lose the muscle mass as well. They need to do the activity, and also they are put on the multivitamin, the calcium, vitamin D, the iron, the B12, all those things. Yes, I don't have any evidence about their thing, but I've been referred by surgical colleagues because they've got a spine problem, they're waiting for surgery, he's 50 BMI. After surgery, his BMI came to 25. So then the surgeons can put all the metal bits they want to.
Thank you, Professor. I think we're going to move into the next session. I'm very sorry. But thank you again for a wonderful talk.
Thank you.
Hello, hello. Stop. Hello, if we can take our seats, please, for the main event of the day. Something we've been looking forward to. It's with great pleasure I get to introduce Dr. Siobhan Steins from Keele University, presenting her work on epidural injections for sciatica, and she's going to talk to us about the latest evidence and current practice. Over to you, Siobhan.
Thank you. Good afternoon, everyone, and thank you to BritSpine for the invite to talk about an area I've been interested in for quite a few years. So I'm a physiotherapist. I work clinically in the kind of triage interface service. Been researching back pain for many years now, and also work academically at Keele. And thank you to NIHR for allowing me this clinical academic role for several years now. So just to definition, so sciatica, really we should be calling it spine-related leg pain with radicular leg symptoms. Sciatica is easier to say, so that's what I mean. And in this scenario, talking about compromise of the spinal nerve root due to a disc herniation. When I talk about ESIs, I'm talking about any type of therapeutic spinal injection that includes steroid and anesthetic, and the routes can be guided with a caudal route, intralaminar, or transforaminal. So sciatica, we know it's very costly to the individual, and we're very much talking about the working age population, so the indirect effects are quite significant on the economy. Just some numbers, which my cousin kindly gave me from the NCIP data. So in 23-24, on average, 51,000 of these, or 51,000 injections are being recorded, slightly down from 1920. I'm not sure why. And the costs, microdiscectomy, around 4,500, and the epidurals, £700. So they're the, I suppose, the healthcare costs, but obviously implications on the individuals as well are very significant, as we know. We do give the positive message with sciatica that your symptoms are likely to improve, but unfortunately they do persist for about a third of patients with symptoms. And this number can vary depending on the trials or cohorts that you look at. And we advocate a stepped care approach, so hopefully being managed efficiently in primary care with medication and physiotherapy, and then obviously stepping up the care as symptoms persist to either injections or surgery. So our NICE guidelines back in 2016, updated in 2020, but the message didn't change about epidural steroid injections for sciatica, that we can consider them in people with acute and severe sciatica. And I'll come back to this acute a few times during the presentation. Why acute from the NICE guidelines? Well, they clarify that, saying that most of the trial evidence in the NICE guidelines came from people with acute and moderately severe sciatica, hence they considered this would be the population most likely to benefit. It's a very popular topic in the literature, and the reviews keep coming. And since since the NICE guidelines reviews, I suppose the big one was around 2021 with the Cochrane review, and this compared epidural steroid injection to placebo, and placebo could have been saline, anesthetic, or an intramuscular injection. The difference between the interventions is there, but this mean difference of minus 4.93, about 5, and that's 5 out of 100 on a pain scale of 0 to 100. The message continues across other systematic reviews that have been done over time. The only I suppose, the group that weren't too happy with these messages is the group down the bottom, and so the Manchikanti trial or reviews in 2022, and their conclusions that is there's strong evidence of effectiveness, and all these they kind of look at eligibility criteria slightly different, outcome measures slightly different, but their argument was that you shouldn't be comparing, the control shouldn't include any type of I suppose active. So they removed anything that included saline or anesthetic, so hence their results were different. They are an interventionalist group of pain physicians. The reviews keep coming, so as I was preparing this, more were coming out. If you are interested in it, the BMJ have just published more network meta-analysis of randomized trials, looking more broadly, but within that they have looked particularly at injections in radicular pain, and then there's a commentary with updated clinical practice guidelines, and I'll just talk briefly about the conclusions from that. And in the same month, Neurology published a similar review on in neurology. So this was the American Neurology Association. So the conclusions from the latest reviews is, again, ESIs can moderately reduce pain and disability for about 3 months after the procedure, may reduce disability for 6 months. The BMJ focused more on what they call chronic radicular pain, and chronic being 3 months or more. And the mean difference, this is on a scale of 0 to 10, is less than 1 when comparing to placebo, or and that included usual care in some of the trials. So they are now strongly recommending against epidural injections of anesthetic steroids or their combinations for chronic radicular spinal pain. They did highlight that the trials perhaps were always focusing on disability and pain, and could be reflecting on other outcomes that are important to patients, like return to work, social and mental functioning, sleep quality, opioid use, and adverse events. So I'm sure most of you are familiar with the NERVES trial, and we saw some lovely longitudinal data presented yesterday, but this very much reflects our setting here in the UK. And I've screenshot from their paper, I hope that's okay, but this was their results figure, and they're comparing epidural transforaminal epidural steroid injections to microdiscectomy, and ODI being the primary outcome at 18 weeks. So your solid line is your surgery cohort patients, and the dotted line is the injection, and clearly there's not much difference between them at 18 weeks. 4.25 on a scale of 0 to 100 on the ODI. And also noting that those who had the injections, it was if they didn't cross over to the surgical group. So in other words, they avoided going on for surgery. And our take-home message from the NERVES trial is that given the unlikely cost effectiveness of surgery, that in our stepped care approach of invasive treatment for sciatica, TFESI should be the first choice. And I think that is what's happening in practice. So going back to this idea of acute, giving the injection in acute sciatica, this was a trial done in Holland, in the Netherlands. So they had patients in there with symptoms of less than 8 weeks, which doesn't often happen in our practice here. But they had 3 groups, small numbers within groups, but it was powered to look at what they wanted to look at. And the figures are leg pain on a scale of 0 to 10. So they looked at epidural steroid injection and usual care. They took out the steroids, so the anesthetic injection and usual care versus usual care. So the groups were well matched at nearly 7 out of 10 on their pain score. And you can see again the number. Everyone's improving, but there's no real difference between the groups, and that was the result of the trial. So they did look at some post hoc analysis and found that those who had the epidural steroid injection, they were reporting less opioid use. So the most recent reviews that I've mentioned, the American and the BMJ, with many of their conclusions, did highlight that we should be looking at. We know patients are. There are patients who are doing very well with this intervention on average. The differences aren't striking, but we should looking at studies that evaluate which patients are more likely to respond, or are there subgroups. I had that idea years ago, and this is what I've been doing for the last few years. And some of you will have recruited to this cohort study, and I wanted to predict outcome in patients following the epidural steroid injection, and had a great mentorship team listed there to support me in this work. And I'll just talk you through kind of the objectives of POISE and the results. So I was looking at several things, but one of the main objectives was, could I develop a prognostic model or a tool to offer patients better information about chances of improvement in leg pain following this intervention? So I'm sure we've had those conversations with patients. You have the scan, they have the clinical symptoms, they're not changing. One of your options is this injection, and what do you say when they say, will it work? So we have the flip of the coin analogy. It's probably a 50-50 chance that it will help. This was a prospective observational cohort study, and it was set in routine care across the NHS. These were patients who had that conversation, so they were recruited when their scan tallied with their findings, and they were either listed or being referred on to see surgeons to be listed for injections. I'll talk about what predictors I used in the analysis, and the primary outcome to reflect what most trials are looking at was leg pain intensity on a scale of 0 to 10. This was collected twofold by a questionnaire that came 6 weeks after the injection, 3 months and 6 months, but also they were sent weekly text messages. We also collected ODI and asking about symptom resolution and if they'd had any further intervention at 6 months. I had 2 years to recruit and needed to keep adding on sites because recruitment was challenging. We had 19 sites in all across England. Unfortunately, we didn't get Wales, Cardiff up and running in time. And 16 of those sites were active in recruiting. The challenge was actually getting R&D at sites to approve the study, which slowed things down. So 707 patients were invited, and of those, 58% consented, so they agreed to take part in this study. 314 were my kind of baseline cohort. We lost others for various reasons. Some filled in the questionnaire after they'd had the injection. Some were deemed ineligible for the injection, and they were the main reasons. Or some, they consented, but they didn't actually complete the baseline questionnaire. They had an option of doing this online or by post. The 6-week outcomes, or the folk who returned our data at 6 weeks, we had 290, which was 92% response rate for leg pain, and that's because of the two-pronged approach of the text and the questionnaire, and slightly less for the other outcomes, because that was questionnaire only. And then the follow-up rates dropping off, so at 24 weeks, 227 with the leg pain outcome, which is our primary outcome. Just to give you a flavour of what this cohort looked like, I'm sure it's quite familiar if you see these patients in clinic. Again, that working age group around 49 on average age, 60% female, 95% ethnicity white, 28.4 BMI on average, and 64% of the cohort were currently in employment, with half of those saying they'd had time off work, fit note or self-certification, and on average 7 days in the last month off work due to their sciatica leg symptoms. We did kind of broke down the duration, but just to give you a reflection, 60% had duration for more than 6 months, and this was just at point of being listed for the injection. There was a very variable wait after that. I think only about 50 or 14% of the cohort had symptoms for less than 3 months at entry into the study. Again, unsurprisingly, most of them had severe back and leg pain, 7.2 average leg pain, and ODI, similar to what you see in these secondary care cohorts, about 46 out of 100. Some data on their general health, EQ5D, and the clinical information collected was 77% had a positive straight leg raise, and unsurprisingly, most had their symptoms in the L5 or S1 nerve root distribution. Asked about sciatica management, what had they done so far for this episode of sciatica. More than half had sciatica before, and we know this is a risk factor in back pain for getting it again. Treatment, be it physio, osteopath, or chiropractor, about 61% had some treatment for this episode. Unsurprisingly, most had prescribed painkillers, 80%, 43% over the counter, and surprisingly quite a few recalled, be it this was self-report, that they'd been given any written information, online information or advice, and 44% said they'd been doing some exercises. So just a flavour of how this group did over time, and this cohort, this is the 290 that had the injection and kept doing the follow-up data over so the time points here is that baseline, and then 6 weeks after the injection. Now that is a very variable time point for the cohort, but on average that 7.1 leg pain is reducing to 4.9, and you can see the standard deviation, the variability around that improvement at 6 weeks, and pretty much staying the same at 3 months and at 6 months with their leg pain. Similar clinical course with back pain. Obviously back pain was a little bit lower. It improved a bit, and that improvement stayed similar to 24 weeks. So going from 6.2 to 4.8 at 6 weeks after the injection. ODI, the scale here is not to 100, that's why it looks a bit squashed. 45.9 going down to 35.8 at 6 weeks after the injection. So we say a 10-point change in the ODI is minimally clinically important difference, so that they are achieving that and sustaining that, this cohort. One of our outcomes was looking at whether they'd, well, ideally I was looking to see if they'd had needed another injection or gone on for surgery, but things don't move very quickly in the NHS at the moment. So I also looked at, or I asked sites to report back if they'd been listed or they were, due to be, they were consulting again with surgeon or sent on elsewhere. So 36% obviously hadn't improved because they were still in the healthcare system. And this very much reflects the NERVES trial data as well. Their recovery, so the green box is patients again reporting if they're completely recovered, much better or better. So 6 weeks at 59%, 51% at 12 weeks, and 54% at 24 weeks. So it's back to that 50-50 analogy. So this idea of how can we select patients how can we target that green box there, that 59%? Who's in there? Why are they in there? Can we predict this? And this is very much about giving individualized prediction to folks. So work was done, and this is published. Firstly, the literature didn't help much as regards looking at prognostic factors in this group. So then I went on to do a expert workshop on Delphi study, which again some of you may have responded to. So about 89 items were generated. So there's a lot of thoughts out there on what could potentially predict outcome. You need an absolutely enormous sample size to look at those kind of predictors. So it had to be shortlisted. And there was agreement through the Delphi work on 14 items. And these are the items. I know it's a busy slide, but I've just highlighted kind of the domains. So there were 3 reflecting pain. There was the type of injection. So we did have a site that did caudal ultrasound injections for sciatica. This is all published as well, so if you don't get a chance to go through it. Medication came out, long-term opioid use. And in the blue, there's 1, 2, 3, 4, 5, 6 psychosocial factors, which was a bit disappointing. And we had a lot of talk within the group because you think, are we giving a steroid injection? Is this, it was kind of thinking about the mechanism of the steroid. But our PPI group were keen that they stayed in. They felt they were asking something different. And we did some redundancy analysis as well. And actually, there was no association between these factors. So they did all stay in the analysis. I had one MRI variable that reached kind of the threshold to be used in the study. I have collected other variables. So that will be a separate paper to look at their association with outcome. So I'm just giving you a very a sort of flavour of the results, and this is still work in progress at the moment. But following the multivariable regression analysis, you can say the factors on your right, yeah. So they're coming out as showing high certainty of effect. And by saying that, I can say their coefficients don't cross the null effect or the 0 point. And that was current leg pain intensity, duration of sciatica symptoms, and patients' treatment expectations. So they were asked on a scale of 0 to 10, how confident are you that this injection that you've been referred to is going to help your leg symptoms? All the others, they had smaller effect size and larger uncertainty, so their coefficients crossed that null effect. So another way of saying that is, if you've higher leg pain intensity, you've had your pain for longer, and we dichotomize pain into less than 3 months. And this was, again, at time of referral for the injection, so I'm not accounting for the time they waited, 3 to 6 months, 7 to 12 months, or more than 12 months. And the lower their treatment expectations, these were all associated with higher leg pain at 6 weeks. In other words, the more you struggle at baseline, our results, our stats are saying the more you'll struggle at follow-up. Now, with this model, you get a very complicated equation, and I could encourage you all to use, you can use it in an Excel spreadsheet, and with someone in front of you, you could go through these questions, populate it, and you could tell your patient, oh yeah, you're 7 now, but based on what I can see, your pain might be 3 out of 10, 6 weeks after the injection. But needless to say, this was the performance of the model. Okay, so I'll probably say to you, no, don't use it, because we can't be very confident in this model. So what this shows is your regression, your R squared, which is 0.24. So the model is not accounting for 76% of the variation in outcome. So if it was a good performing model, all those blue dots would be clustered around that best fit line, that red. So for example, if you want to predict someone's leg pain, say it looks like it's going to be 5 out of 10 based on my model, but actually if you look at those dots, it could actually be 10 out of 10 or it could be 0 out of 10. Okay, so that's what's come out of the analysis. So my final thoughts from this journey, and we're still analysing other results. Sorry, I wasn't close to the mic. Hope you can hear me. So at a population level, and we know this intuitively as well, when we see patients, we know it works for some, and surgery is avoided. Currently, we don't know how to predict this, and my study, and I'm not hugely surprised, isn't really adding or helping with this. And there, we can discuss reasons for that. Potentially there are other things out there we can measure. As I say, we had a massive list generated, but you have to a priori, you have to have a plan. And our statistician Kim Snell was very keen we stick to the plan. Perhaps biomarkers. I know Oxford are doing some exciting work, but then how is that going to work in clinical practice? Very clear, very strong message from this across the country. People are waiting a very long time. I talked about duration of symptoms, but on average, I looked across, so we had 16 sites recruiting, and on average, patients were waiting 9 months for injection. There were some outliers, so I know some of you out here have a nice acute radicular pathway, but on average 9 months. So this idea of the BMJ saying it's not working in chronic radicular pain, I think we need to have a think about this. So my message is, can we improve waiting times? And perhaps that's a conversation that can be taken forward. That's a system approach, I know. But in the meantime, yeah, it's keeping up those honest conversations with patients. We talk about shared decision making. Maybe there'll be a bit of self-selection from patients when we can use our epidemiology data a bit more clearly as regards their likely change in their leg pain or their symptoms with this intervention. So I'll leave you with those thoughts. Thank you very much.
Thank you, Siobhan. And questions, please. Stephen, here we go.
Hi, Siobhan. Great, but maybe a bit frustrating work after all this time. I wasn't sure, but it struck me one finding there might be really significant, and it was the little bit of caudal versus lateral. And if that isn't a predictor, because I remember at the NICE guidelines talking about this bit, the caudal kind of, some folks sort of do this in the shed in the garden, and the lateral is kind of expensive-ish and controlled in the theatre and things like that. And if there's no prediction between the two, does that have economic ramifications, or was there not a big, I know you had trouble with sample size in your regression, but, or is that, am I reading that wrong? Not enough data?
No, good point. So you couldn't answer that question from my study, but you're right. It was highlighted in the NICE guidelines. The evidence isn't showing any difference between the approaches. I know it's best practice to do the fluoroscopy guided, but there are the costs and the waiting times. So the only outlier there was actually our service. So we do have an AHP that does caudal ultrasound guided injections, and we can get them in quite quick and show good results. But we tried to set up that, Kika did try and do this just before COVID, so comparing guided transforaminals to ultrasound, but I think struggled with buy-in from sites and equipoise, and then COVID hit. So yeah, it is still an area to look at. Thank you. Thanks, Steve.
Thanks, Stephen. Next question.
Jennifer Morwick, I work in Cambridge. Thank you for a really good study. It's just nice to know that we probably see that in our clinical practice. I was just having a question really about the weights for epidural. In our area, we utilise the pain service, so it's a separate route in,
but they call it fast-track epidurals, but they're generally seen within 4 to 6 weeks from referral. And my thought was, does anybody else use that kind of service? So it's separate referral in from the pain service, and they're using that because actually their theatre spaces are reducing because of the fact that they don't need to do so many injections, but actually the epidurals are still funded.
Yeah. I think these are conversations that could go forward. There's, you know, I've was engaged with a lot of sites and more that weren't able to come on board, and just that variability in different pathways. And it is working well in some areas, but not working so well in other areas. So thank you for highlighting that, and let's keep that conversation going.
If there are no more questions, I'd like to thank Siobhan again, and it's time for lunch.